so let's talk a little bit about diseases of the small and large intestines. Now, I would have loved to put, let's say, disease of just the small intestines and then disease of the large intestines. But there's a lot of them that are just overlapping. I just put it all in one. It's just easier to deal with. Okay? So we have something called Ileus. Ileus is basically the larger small intestines. There's no peristalsis going there. Remember, peristalsis is the milking of the food forward, right? You have the smooth muscles around the intestines, and the way that they coordinate is that we're able to make the food move forward. But if there's some kind of absence of the peristalsis, then the food is just going to sit there. The gas is going to sit there. So basically what ileus is that the intestines, well, the intestines is paralyzed. All right? So we talk about paralysis of the arms. Think of paralysis of the intestines. The movement of the food is not going anywhere. It's usually due to a few different things. Post-abdominal surgery. Whenever there's some kind of manipulation with the bowel, whether the small or the large bowel, we don't understand the mechanism, but when they open you up and they got to do any kind of surgery and they got to move the bowel a lot, that tends to make the intestines not want to move as much. Okay? Adhesions. Who here has heard of adhesions? These are nasty critters. Adhesions is a difficult thing to define, but adhesions is kind of like, you see how my hair is like you can move it all around, right? Whatever I have left of it. Now put some glue in there, or put some silly putty in there, or put some gum in there. Now it's hard to actually separate everything, right? That's what adhesions are. And I'll show you what that looks like in a moment. But adhesions can be caused by a lot of different things. Adhesions can be caused by surgery. In other words, if I make an incision over here, and now it's open, and then I just let it sit there, it could actually fuse in a weird way, and that can cause an adhesion. You want it to close properly, not crooked, and that could be attaching to another organ. So in other words, if I make a cut here, and then I have another, let's say the intestines over here, it could actually glue over here, and now you got an adhesion. You've got to like separate it. You know what I'm saying? So that can cause it. Infections can cause it. We'll talk about peritonitis later. We'll talk about pelvic inflammatory disease. These all will cause gluing to happen between structures in a very odd or abnormal way. Blood can also do that. If blood is in the abdomen, that would cause a lot of pain. If blood's in the abdomen, the blood will actually use as like a glue that would be making the structures glue in a very odd manner, and that can cause problems too. So adhesions are notorious for causing a lot of different things. Okay? Severe infection, trauma, also hypokalemia, right? You remember the smooth muscles in small and large intestines. There's all action potentials that go over there. So if you have hypokalemia, it's going to slow down the action potentials, which means that the food and the peristalsis is going to be moving slower and slower and slower. So if people have low potassium, that'll also cause this. So how do you treat it? Well, you just, whatever it is, you just correct the cause, whatever cause it is. So a little bit more about the post-operative ileus when we're talking about post-abdominal surgery. So I'm not talking about surgery of the knee or the foot or the head. I'm talking about if you manipulate the bowels, okay, abdominal surgery. You get this peristalsis, and it takes some time for it to start moving, okay? We don't know the mechanism of why that happens, but it happens quite often, okay? So the way you treat it is you give IV fluids. The more fluids, for some reason, the fluids get into that area, it starts perking up the area and start moving. The other thing that we have them do is ambulate. What does ambulate mean? Yeah, walking, okay? So so after they had surgery, the following morning, if it's possible, we want them up walking, okay, as much as you could do. All right? The walking will actually make the intestines move a little bit, you know, mechanically like that, and I guess it just kicks them on a little bit and they're able to move. These are one of the things we want, you know, when we ask the patient the following morning, did you move your bowels? Chances are no. Okay, no problem, that could happen. But are you passing gas through the back end? Ooh, no, we need to know. Because if you're passing gas, that means there must be some kind of peristalsis that's pushing the gas forward. It's a good thing. We'll laugh with them, okay? It's fine. But you and I need to know, are they passing gas? If they're not passing gas, that ileus is too strong, right? We got to see what we're going to do, all right? So that's what's going on with that. That's an adhesion. So here's some fatty tissue, let's say the greater omentum or something like that, and here's the intestines. So you have this adhesion that goes on here. You can see that that can actually pull this area in a certain way, and it can almost kink this and cause an obstruction. Or it might just pull a little bit, and the nerves that go over here are not working as well, and we got to just have them walk a little bit. Now you can go in there and cut these adhesions, but we got a problem. You're doing more surgery to do that. And surgery can cause adhesions. So you got to weigh the pros and the cons. You ask the patient, how bad is it? Because when you do surgery, there's a good chance you're going to have more adhesions. You know, oh, it's hurting too bad. Okay, well, we'll cut this, and hopefully you don't have any more adhesions, or at least you won't have adhesions in an area that's going to cause pain. Right? It's a kind of a catch-22 with that. Okay? All right, we have this intussusception. Intussusception is a telescoping of one segment into another one. Best way is just look at the picture over here. All right, so this is like your intestines, and part of it actually goes inside of it. All right, we see this very common, we don't know what causes it, but we see it very common in infants. All right, we don't see it in adults often. We see it in infants. The problem is, as it goes like this, it can get inflamed because there's a lot of pressure going on here as food's trying to get through here. And this can actually cause the food not to move forward because there's so much pressure going on over here that it's going to put pressure on those nerves, and you're going to have some kind of ileus, or the peristalsis is not going to happen, and it can cause obstipation. Keep in mind too that blood vessels are alongside of here. So when you have the blood vessels going on either side, and now you're having it where it's going to be very tight, you're going to be blocking the blood flow because it's going this now. It's supposed to go straight, but now the blood flow is going to be kinked. So you're going to cut off blood flow because it's going to be tight in there, which means that this area here is going to get ischemic and eventually be necrotic, and now you've got a dead tissue there. Okay? Very common with that. So how do you get rid of it? Well, simple surgery, you just remove this area and then you tie this area to that area. Okay? But this is an infant. Then we have a volvulus. In a volvulus, you get this twisting going on. This we see in adults. Okay? When this twists around, now the food has problem, can't get in through here, which means it can't go forward. This causes major pain. Not because it's just the food being obstructed here, but the blood vessels. Blood vessels are riding alongside each one of these, and it gets twisted, so now you're cutting off blood supply to this area here. Causes ischemia, and it eventually will cause necrosis. That area is going to die, and you're going to have to cut here, and then reanastomose it. Okay? Twisting of the area. Does this make sense? When we talk about ovarian torsion, we're going to talk about twisting also, or testicular torsion. You got to understand the twisting is going to block blood flow going to that area, and then you lose that, whatever that area is. And over your testicle, you'll lose it. Okay? Hernia. All right? It's a protrusion of the bowel through some sort of dilated anatomical space. Okay? So if it goes through that, it's called what we call a hiatal hernia, like we just saw. The diaphragm, you know, the hiatal hernia, the diaphragm is opening a lot more. There's an opening there. And then you got part of the stomach going right through, herniating into that area. Okay? You can also have a defect. Any scar is not going to be 100% strong. All right? Your skin is 100% strong. You cut there and then you sew it up, it'll never be 100% like it was before. You lose 10 or 20% of the strength. So therefore, if you have an incision over here that you had surgery, there's a way that there can be an intestine going through there. It can bulge right through there. All right. The bigger you are, the more coughing you do, that this is going to open, allow bowel to go out there. Okay. The loops of bowel may be trapped in there. Contents will be obstructed, cause obstipation. Okay. Blood flow, big thing on there that can cause bowel infarction, necrosis. Okay. Umbilical hernia, that's where the umbilicus. It's an area like where your belly button is, but there's an area around it too that is weak. So there's an area there that can be weak and open up, and part of your bowel can go through there. We see that in a lot of older patients too. You could also have an inguinal hernia. We see that a lot more in males, where you have an inguinal canal that enlarges, and now part of the bowels can go through the inguinal canal and enter the scrotum. And it could, most of the time, you could push it right back up, but a lot of times it's not retractable. You can't push it back up. So now it's going to be incarcerated. It's going to be, you're stopping the blood flow there. It's going to cause pain. You got to go in there. You got to fix it. Okay. So here's a couple of them. Right. Here's your umbilical hernia. Part of the bowel is going to go right through there. That can get incarcerated. When I say incarcerated, it can be necrotic and die down. Or you get part of it actually go into the scrotum and it can't get back up there. There's going to be a tightening here, and you're going to lose this part of the bowel. Okay. Hirschsprung disease. Hirschsprung disease is also known as congenital megacolon. Okay. Think of this. This is where mega meaning big, colon meaning colon. So what's going to happen here is this. If you have your colon that's over here, okay, and for some reason, well, we have parasympathetic nerves going over here. The parasympathetic nerves are going to be able to make that bowel move for peristalsis. But for some reason, I don't know, multiple sclerosis, whatever, there's some reason where part of the nerves are not going to be firing to a certain segment. So now you've got movement of food here, but nothing here. So that means this is going to not move, so the food is going to start doing this. And since this isn't, well, it's really not doing that, it's just that the food can't move this way. So therefore, the area up here is going to start getting bigger. Backup of food, right? All this stuff, like I did my father and stuff, it's all about backup. You need to know blood flow. You need to know flow of stuff, flow of food. And then you can understand the backup. When you have backup, then you can see all the symptoms that's happening. So that's what's happening with this, is that you're going to have this backup. I'll show you pictures of that. More males than females have this. 1 in 5,000 births. We usually see it in young, in infants. Okay, and really, what you end up doing for something like this is just simply, let's just take this section over here and remove it, and then we tie this part over here to this part over here, and voila, it's all fixed. It's simply more complicated than that, but that's basically what they're doing. Okay. So you've got this situation here. So here's the colon, right? So here's the area that's not getting innervated properly. All right. So this is the what we call aganglionic portion. So this is the portion that doesn't have the nerves going there properly. So therefore, so there's nothing going on down here. The rectum is completely fine. But because this can't move food forward, then there's going to be a backup of food that's happening here. So this is going to get dilated, megacolon. Right? And all of this is going to get backed up. So the whole colon gets backed up, and you can see where it's coming from. When they do, and this is probably a barium enema, right? So what they do is they actually put food from the backward, or I'm saying dye from the backward, from the back end. And what happens here is that when they shoot it up, you'll see that this is the area where the culprit is. And then you'll see that this is enlarge. All right, does that make sense? Right, megacolon. Okay. Gastroenteritis. Okay, gastroenteritis. Now, we really should be calling it entercolitis. Okay, now let me just give you the prefixes so you understand what's going on. Gastro means stomach, entero means small intestines, colo means large intestines. So it really should be called enterocolitis because the only place in the stomach that actually causes gastritis, really, in terms of infection, is H. pylori. All right? So we refer to, the newer term should really be enterocolitis because we're really dealing with this small and the large intestines. Otherwise, we're talking about gastritis. Okay? But a lot of people, and myself, we're still using, because your books use it everywhere, we still use it gastroenteritis. But you're going to see it really should be called enterocolitis. Okay? So we have viral gastroenteritis, and this is actually spelled wrong. I'll fix it. It should be ROTA virus. Rotavirus. Okay? This is the most common cause of diarrhea in young children. Okay? So I kind of use the abbreviation. ROTA is right out the anus. Okay? So, but when you think somebody, a child, let's say 5 years old, who has a lot of diarrhea, that has a lot of dehydration, you're thinking of a viral reason. And there isn't much they can do about that. Just get them in the hospital. They're that bad, dehydrated, and just the fluids. It'll usually go away, in a week or so. We also have the norovirus, or also known as the Norwalk virus, and this is the most common cause of acute gastritis in older children and people like you and I. All right, when you refill your stomach, you got the stomach bug, right? And you're vomiting and diarrhea, you got fevers. Good chance it's probably this. It'll go away by itself. It'll probably go away in like 2 to 3 days, as you've seen. All right, but you usually have the diarrhea and vomiting, but that's usually the reason why. Now, bacterial reasons. Okay, so there's a little bit of a list you got to know over here. These are the more common ones, so I want you to be aware of them. This is less common than the viral gastritis. Okay, but these are the ones that would be common, and these are the ones that you'll see on your NCLEX and other tests. Okay, they're usually due to exotoxin releases from bacteria. So we have this Campylobacter jejuni. This is due to undercooked poultry and eggs, peanut butter, and it usually resolves in 5 days without any treatment. So it looks very similar to the viral causes, but it's usually led to because you took, these are like the types of your food poisoning, so to say. Okay. You have salmonella, right? Now salmonella can do 2 different things. This is Salmonella enterocolitis, and this will actually cause a lot of these sudden fevers, nausea, vomiting, a lot of GI upset kind of stuff. All right, and it's due to, let's say, peanut butter and poultry and eggs that's undercooked. But then we also have Salmonella type D, and this causes typhoid fever. This is more of a slow onset of headache, sore throat, bloating, rash, diarrhea. Okay, so that's what usually happens to that. So you ever hear people on Salmonella, we're looking at those 2 things on here. Then we have Shigella, and as I mentioned before, that's our dysentery, right? That's the painful, bloody diarrhea that comes out. E. coli. These are the ones that you, I think a few years back, there was a big epidemic where Taco Bell had to shut down, or they couldn't serve their it's usually found in ground beef, right? The ground meat. And they had to shut down a little bit for that. So undercooked ground beef, unpasteurized milk, contaminated water, you have bloody diarrhea or water diarrhea. Right? So that's what happens with that. Now this next one is a biggie. I definitely think you will have a lot of questions on the NCLEX of this. Clostridium difficile. All right, C. difficile. All right, or better yet, a lot of people call it C. diff. Who here has heard of C. diff? Okay, this is a big one. You definitely need to know about this one. This causes what we call pseudomembranous colitis. It's rare, but when you do get it, it's severe, okay? It's normal flora in 5% of people, and that's why we need to see this. We don't see it as much because it's in 5%, but who's the 5%? You know what I'm saying? If you have 100 people here, 5 people have it. You don't know who's the 5%. So what happens here is this. the person is on broad spectrum antibiotics for whatever thing. And you usually see in the hospital, okay? Not all the time, but hospitals are usually known for this. So you're on this broad spectrum antibiotic. Maybe you got pneumonia, so you're on this IV medications for like 2 weeks. What will happen is it's going to alter the normal flora of the intestines. You got a lot of bacteria in there. And what will happen is in the people that have C. difficile, it's going to make the good bacteria die and the C. difficile grow. Right? We've seen situations like that, right? So the C. difficile overgrows and damages the mucosa of the colon. And what happens is that they end up getting a lot of pus and dead tissue that clings to the mucosa, the inner lining of the colon. So it's not a true membrane on the colon. It's all this pus and dead tissue, which is why we call it pseudomembranous colitis. And this causes a lot of diarrhea, right? Very contagious. But the typical case that you should see as a nurse, because I know when you go in the hospitals, you will hear this hospital has a lot of C. diff, or this hospital doesn't have a lot of C. diff. You've got to keep up with this stuff. This is all over the hospitals. And you've got to be able to think about this. Suspect a patient who is hospitalized because of whatever, pneumonia, and they're on chronic antibiotics, and all of a sudden they got a new onset of diarrhea. Okay? Start treating them on that. And you'll learn about treatments. There's one we use as metronidazole, right? Metronidazole and Vanco. But the key thing is with Vanco and metronidazole, you could give it IV. Not for this. You have to give it by mouth. Okay? So why you need to understand that concept, because a lot of patients who have pneumonia, they might need big guns of pneumonia and give them something called vancomycin. All right? I'm not going to ask you about these medications, but I want you to see where this is going. They may already be on vancomycin through the IV. So the easy thing is like, oh, we don't have to worry about C. diff because they're already on Vanco. No, because that's not going to kill the bug. It has to be given by mouth. Even though you get an IV here, it doesn't work. It has to be going through the intestines so it reaches where the problem is. So do keep in mind, I won't ask you about that, but when you take pharmacology, it's important to know how the medications are taken. Okay? So it's for your future, man. But yeah, it's pretty bad, yeah. Yeah. Oh yeah, yeah. The C. diff is yeah, it's pretty bad, you know, it's pretty bad. Hospitals always want to keep the C. diff rate very low, like bed ulcers. They always want to keep that low, you know, it's not a good thing on that. All right, so that's what's going on with that.